Again, I'm Louise Kenny. I work with David and Chris and a team on the special events group, and we like to think we're a fun group. We certainly engage very interesting topics, speakers for very interesting topics. Perhaps the most interesting and relevant today is what Jay is going to talk about relative to ethics and public policy relative to the pandemic, the whole balance between individual liberties and the pandemic and the health needs of it. Jay is a Senior Policy Analyst with ACLU's Speech, Privacy, and Technology Project. That's the national organization. He's based out of New York. He's also done hundreds of blogs and influential reports and policy papers for the ACLU, particularly around new and emerging technologies, including a piece on pandemics including Ebola and now COVID. So his expertise is totally right on right now. He's also an experienced strategist and spokesperson, and you'll perhaps have seen him quoted in the press, both broadcast and print. So Jay, we're thrilled to have you. Thanks for educating us on an important topic that we're really all have a vested interest in and very interested in. Jay?
Many thanks, Louise. It's great to be here. Look forward to talking to you all. I wish we could do this in person. We have much better back and forth and conversation that way, but it is what it is. And part of what it is what we're going to talk about, I guess. So yeah, I work for the National ACLU on the sort of technology and privacy project. And that includes sort of science issues, such as genetics and such as communicable diseases. I'm not a lawyer or a litigator. I was originally trained as a historian, but my job is to sort of help the organization look at what's coming in terms of different technologies, things that are new, and help the organization figure out what we should think, how to talk about what we should think, and to how we can communicate to the public what we think good policies are. So I'm going to talk about civil liberties and individual rights and communicable diseases in two parts. The first part before COVID and the second part COVID. And in the before COVID section, I'm going to talk about 4 different incidents that sort of shaped the ACLU's approach, our thinking about civil liberties, and also were the context when COVID arrived, when it came to civil liberties issues and communicable diseases. I'm going to start with what, of course, is the first great disease outbreak in my lifetime, which is, of course, AIDS. And then I'm going to talk about what wasn't a disease, but was more an incident, which is the post 9/11 pandemic preparedness and frights around the anthrax attacks that you all may remember happened right after 9/11, a time when there was a huge amount of concern over bioterrorism. I'll talk about the H1n1 Swine Flu and then about Ebola, and then we'll get to COVID itself. So, you know, the ACLU, we're an individual rights, civil liberties organization, and we've struggled with how to balance and preserve individual rights, privacy, while respecting the seriousness of communicable diseases. In many ways, communicable diseases, individualism breaks down with a communicable disease because at the end of the day, we're all one big biomass. And so how do you balance that? And with AIDS is the first time, at least in it was before my time at the ACLU, but sort of in the institutional memory that I received, that we really struggled with that. And we came up in a 1987 policy with sort of a 5-part framework for how to analyze it. Every communicable disease, we decided in our position, should be examined in terms of the following factors, 5 factors: the gravity of the harm of the disease, the specific characteristics, such as its contagiousness, the means of transmission, efficiency, the likelihood of the behavior that enhances transmission. Number 3, the degree of intrusion and duration of the proposed public health measure that impinges on individual liberties, the effectiveness of the proposed public health measure, and the availability of less restrictive alternatives. So, you know, every disease is different, and I think that's a big theme that we see when you look at the larger history of the response to communicable diseases, and they all have their own characteristics. And so this sort of 5-part framework sort of aims to be flexible in terms of the specific situation that arises, and to recognize that, you know, there can be situations where civil liberties incursions can be justifiably, you know, done. On the other hand, you know, just because something is effective doesn't mean that it's proportional. You could perhaps stem the spread of the common cold by closing off the borders of California, if the common cold one year happened to originate there, for example. But I don't think most people would think of that as proportionate, even if it would be effective, which it probably wouldn't be. You know, so that was sort of the origins of our struggle. And of course, AIDS had its own particular characteristics. I'll talk about that a little bit later, but you know, it had a you know, stigma attached to it, of course, and so that increased privacy issues, and it was not very easily transmitted, so that sort of shaped the response to it. The second one I was going to talk about is sort of the Bush administration's pandemic preparedness, again in a post 9/11 climate when everything was about terrorism. And we had in fact, anthrax attacks. There was a lot of push by security agencies and the Bush administration to put in place sort of pandemic preparedness, seen in very distinctly through the lens of national security and police. And we were very critical of this because it was a very sort of militarized and law enforcement based approach to public health. There was something called the Model State Emergency Health Powers Act that was circulated in the Bush administration. And we and a number of others were very critical of it. It was revised some, but it was pushed through a number of state legislatures. It included extraordinary emergency powers with a complete lack of checks and balances, overbroad definitions of public health emergency to include HIV, which is still with us, sort of, you know, greatly diluting the definition of the word emergency, and a lack of privacy protections and other civil liberties protections. And we saw legislation of some kind enacted in 25 states in these years. Basically, all states in the US give the governor the authority to declare various types of emergencies. Sometimes the state health officers can declare emergencies. Sometimes local governments can. Governors are often required in many states to seek legislative approval for emergency within a given time or for a renewal. And by declaring an emergency, it typically activates emergency centers and plans and frees up funds, relaxes regulations, and grants immunities and liability protections. And there's a federal emergency power as well. In 2005, the President Bush expanded those powers. So we prepared a paper in 2008 that we commissioned from some very prominent epidemiology experts, and basically took a critical eye on the sort of law enforcement national security approach to disease that was then being pushed. And it's interesting to go back and read that now, because in many ways it was the experts who wrote about it were very prescient, and it's a reminder of just how much the expert sort of community and epidemiology knew what was coming. They had a thing about if an outbreak can be localized to one city, rural area, or town, the strategy could be to isolate the area from the rest of the world. But almost all public health officials believe this strategy will fail, and at best will buy some extra weeks for the rest of the world to prepare for a pandemic. And of course, this was exactly what we saw play out with regards to China. They had a section on acceptable and unacceptable ways to ration vaccination and treatment. Quote, the decision about who should get the next ventilator or ICU bed should be made by physicians following medical ethics and triage rules. So this was again in 2008, and it really anticipated many of the problems that we're dealing with now. And they concluded that, quote, the public health community has learned over time that treating people with dignity and minimizing incursions on their freedoms is the best way to fight disease. Unnecessary incursions on civil liberties are counterproductive from a public health standpoint. And this is something that the public health profession as a whole has long found, which is that using force and coercion is often counterproductive in their area because it leads people to go underground, to evade the authorities instead of seeking help from them and so forth. And of course, that gets to the heart of some of the discussions that we're having at this very moment. The third of the four sort of COVID things that I wanted to talk about was the H1n1 Swine Flu in April 2009. This flu appeared in Mexico and it created a fair amount of panic and hype in the US. It all turned out well, but it still offers lessons. The flu soon spread to the US, and by June it spread to 74 countries on all continents. And within 2 months, the WHO classified it as a level 6 pandemic. It had a very high rate of transmission, and some severe cases in young people raised alarms. But the case fatality rate fell because of a bigger denominator, as we realized that there were many, many, many mild cases that had not been detected. And the case fatality rate ended up being 0.02%, basically a normal seasonal flu. But it still created this huge hype. Unlike Bush, President Obama responded pretty calmly and rationally to the outbreak by encouraging people to wash their hands and stay home when sick. Senator John McCain and some other US legislators suggested that closing the US-Mexico border should be an option. Obama basically responded correctly that this would be akin to closing the barn door after the horses are out. And Obama took great care to sort of communicate openly about the potential risks and help to minimize stigma and discrimination associated with the flu by using the term H1n1 influenza and discouraging the use of Mexican flu, which term was often being used. So again, it made the point that civil liberties protections are part of and not in conflict with public health in general. And then finally, in the pre-COVID era, Ebola. So there was enormous Ebola outbreak in 2014 and 2015 in West Africa, and a huge US scare, as what epidemiologists call sparks from the epidemic, landed here, although it never really caught fire here and spread throughout the communities. And we did a fair amount of, got a fair amount of questions from media and so forth about it. And we basically said, you know, that there shouldn't be a sort of a law enforcement approach. We opposed travel bans and border closures, and we opposed quarantines. And then in 2015, we, along with the Yale School of Public Health and Yale Law School, wrote a big report sort of looking back at the Ebola outbreak. And one of the big points was that we were very critical of quarantines for Ebola. Now that may surprise you, like, wait, what? Ebola, one of the most dangerous diseases in the world, you're against quarantines for that? And to understand that, of course, you have to understand that for epidemiologists, the definition of quarantine is when you are isolated before you are sick or show symptoms. After you show sick or symptoms, public health people call that isolation. We are not against isolation of people with Ebola, obviously. But again, and this gets back to the specificity of every disease, Ebola, unlike COVID, is not contagious until after, in many cases, well after symptoms begin, thank God, because we would have been in big trouble if that was not the case. And yet there were calls to quarantine asymptomatic doctors who were coming back from West Africa after, you know, serving there. There was a woman named Stacy Hickox who was forced to live in a tent on the lawn of a New Jersey hospital by the governor. And this was, in our view, a civil liberties violations because it was not medically justified. And it was also stupid and counterproductive because these were people who were going to West Africa to fight the outbreak so that it didn't spread to the rest of the world, including the United States. Heroic people living under very difficult and dangerous conditions in West Africa, and then to have them come back home and be stigmatized in that way was not just scientifically unnecessary and a civil liberties violation, but tremendously stupid. Overall, the government then did a pretty good job in the face of immense public pressure, stirred up by all kinds of some of the governors and some people like Donald Trump, who tweeted out wanting, you know, close the borders now, and wanted to stop all airline traffic from Africa, the entire continent. And the White House resisted calls for travel bans, tried to persuade the governors of New Jersey and New York to reconsider their quarantines, basically followed the advice of public health experts, took helpful steps like expediting emergency FDA authorization for the use of new rapid Ebola virus detection machines. There were some missteps. There was a promise to, quote, stop Ebola in its tracks, which fed politicians angst about that when they were unable to do that because it wasn't realistic. And imprecise guidelines, which basically gave way too much latitude to local public health officials. So, there we saw an example of, teetering on the edge of public hysteria and a real potential. We also saw stigmatization of people from West Africa, which is something that epidemiologists say goes far, far back in history. Which is the tendency to blame and stigmatize already often marginalized groups for any disease. That's a very consistent trend throughout time. And we saw that in the Ebola case. So let me pause here and ask if people have questions about sort of the history of communicable diseases between AIDS and Ebola through the lens of the ACLU.
Jay, we did have a question about if a person's let me just read it exactly. Oh, here it is. She says, I'm late in coming to this, but thank you for the program. My question as a Fairfax County Park Authority, once a week exercise teacher, we are going back to in-person classes. I'm not interested in teaching anyone who is not fully vaccinated. What rights do I have?
Yeah, thanks for that question. So I'm going to bracket that and come back to it because I'm going to go through some of the COVID issues and I will get to vaccination, which is obviously one of the, at this moment, probably the biggest one. And we can talk about that.
Okay.
So, COVID arrives. I wrote a piece for the ACLU on January 28th, 2020, what you need to know about the coronavirus outbreak, a civil liberties perspective. And I said something to the effect of like, we don't really know if this is going to turn out to be bad or not, but if it is, I sort of made 3 predictions about how things would go based on my experience with these previous public health issues. Number 1, I warned that if a crisis developed, that many would not listen to science. Check, nailed that one. I warned that vulnerable populations would be blamed and stigmatized and targeted. That did happen. We saw that with Chinese and other Asian people early in the pandemic. And I warned that the government in general and President Trump in particular was likely to panic, overreact, and attempt to be tough and use the crisis to grab power. Well, 2 out of 3 isn't bad. I was completely wrong in that prediction because, of course, President Trump completely underreacted to the crisis and tried to ignore it and wish it away rather than overreacting to it. But so that prediction was based on sort of the Bush administration's approach and other things that we had seen. I'm going to talk about 5 different areas of civil liberties issues, and again, my talk today is very broad, and some of the stuff I'm talking about I know in great depth and I can talk about at length. Other stuff I am less expert in and am pretty shallow there, and I won't be able to answer very many questions. So, but ask away, and I'll just beg off if I don't know the answers. But I'm going to talk about 5 areas of civil liberties issues and lessons. Again, coming from my particular perspective, a little bit working on technology and privacy issues, which is the set of issues that I know best. I'm going to talk about attempts to sell technologies, technology-assisted contact tracing, vaccines, and then I'll talk a little bit at the end about religion and treatment of prisoners and detainees. So that's 5. So let me start with number 1. Attempts to sell technologies. One of the things that we saw during COVID was that a lot of parties, number 1, as we see in today's world, try to see technology as the solution to all problems, including social and public health problems. And we are living in the midst of a technology revolution with many amazing innovations. And so it makes sense to try and figure out how we can use these new technologies to try and, save lives and restore our freedom from this terrible outbreak. We saw a number of ideas for leveraging technology, and certainly, given the urgency of the situation, none of them should be dismissed, but we also shouldn't give up critical rights and freedoms unless a proposal is necessary, effective, and proportionate. And we saw a lot of proposals that were not effective or proportionate, and I think there are lessons there. One of the areas we saw is remote learning. A lot of school districts have been distributing software that spies on students that it's supposed to help. Some of these products are provided free, as if as a wonderful gesture by technology companies, but they also maybe require the collection of a lot of very personal information about students and potentially spy on students. And so we've called on school districts and governments to require that technology not be conditioned on students allowing companies to gather up their personal information, that they disable surveillance functions that aren't necessary and strictly needed, including communications and social media monitoring, keyword alerts and the like. There's an enormous business out there of monitoring students extremely closely, and of course there are some hard issues there, but a lot of the spying goes beyond any hard questions. We also saw immunity passports as a proposal, and I want to stress that this is separate from vaccine passports, which I'll get to, but immunity passports was an idea early in the COVID outbreak that, well, those people who've already had COVID are going to be immune to it, so why can't they all get together and go to a rave in the basement of a building without having to worry about distancing and so forth, because they're not at risk. And if we could just give them some sort of electronic passport, then we can free up those who are immune. And this is before vaccines arrived. We objected to that. The problem is the science didn't support it. We didn't really know for how long you were immune after getting COVID and how strong that immunity was. It now appears that it's less strong than the vaccines in some cases, according to some indications at least. Another problem is that it would incentivize people to get COVID in order to get immune. If you need that factory job to avoid losing your home, and the only way you can keep that job is if you have an immunity passport, then a certain number of people are going to intentionally expose themselves to COVID, just like they used to do with the chickenpox parties, in the hope that you don't get that, your number doesn't come up on the roulette wheel and that you survive it. The people who would be forced to do that would, of course, disproportionately be people who in essential industries, whose workers can't work from home, who are generally low wage earners, disproportionately people of color and immigrants. And it would also create privacy problems by creating sort of new centralized infrastructure for the collection of health data. Another sort of technology that we saw sold hard by companies in Ebola was, in the current pandemic, was fever detection. Here in Arlington, I often go swim at the public Arlington pools, and they always point one of those temperature guns at my forehead. And a couple of times I've asked them what the reading is, and if that device had been correct, they should have called an ambulance on me, because my temperature was dangerously low. And I did a white paper on this, and if you look at the technology, especially of contactless temperature screening, which is really skin temperature screening, and fever detectors, they are incredibly ineffective. Obviously, there are a lot of, with COVID, there are a lot of people who are contagious but aren't having a fever or any other symptoms for that matter. And basically, experts said that this is a terrible way to try and stem the spread of the disease. But we saw this huge land rush by companies selling not only sort of temperature guns, but also fever detecting cameras, thermal cameras, which are even less accurate than the temperature guns. and and often in violation of FDA guidance for how those things should be used. And then we saw the final technology I'll mention here is drones. There was a town in Connecticut that bought a purported COVID detecting drone that would fly over parks and so forth, use a thermal camera to try and detect who has temperature, look for people coughing, and the like. And it was quickly, the Connecticut town quickly reversed itself due to public outcry, not only because of the privacy issues and so forth, but also because it was just ludicrous as a technology matter. It was utter snake oil. And we've seen drones flying over parks in some cases looking for social distancing violations. I mean, I don't know how the drone is supposed to know which people are members of the same household. And you know, these things are loud, they have short battery life, they're not permitted by the FAA to be flown over people in general or beyond the line of sight of the operator. And really, I think their purpose was more to acclimate people to drone surveillance than it was to slow COVID. So, you know, this is, as I said, revealing about a sort of technology as a solution to everything mindset, but it also is a reminder that when solutions to problems to communicable diseases are proposed, you need to be skeptical, very skeptical. Being skeptical right now is not necessarily a message that resonates a lot because we're probably suffering from an excess of skepticism at the current moment, but nonetheless, the point remains, and it is possible to remember that we should be skeptical of proposals that affect our civil liberties, that empower certain people, that help people's business, while at the same time understanding the areas where you should not be as skeptical. I'll pause here to see if there's any questions about what I just talked about.
Not relative to that, Jay.
Okay.
So I think you can continue.
Okay. So the second of the 5 areas that I want to talk about is sort of technology-assisted contact tracing. And then I'll get into the vaccines. This was a more plausible technology used, sort of way to use modern technology to sort of try and curb the pandemic. And the initial proposals were to use location tracking on everybody's phones. You know, your phone does know where you are roughly, or sometimes precisely, because it needs to know which cell towers you're near so that the companies can route calls and data to your device. And the proposal was, well, why don't we just like track where everybody goes, and then if somebody's sick, we can use that data to figure out who they were near. However, the location data is not nearly not accurate enough for that kind of an application, and the privacy issues are huge here because you're talking about basically sending location tracking of everybody in America to some sort of centralized system. A more effective and less objectionable proposal was to use the Bluetooth function on phones. Bluetooth, of course, is a shortwave radio that only goes about 10 to 20 feet, you know, used to wirelessly connect to headphones and so forth, and to your car. And if everybody's had their Bluetooth turned on in their phone and was wandering around through their lives, the phones could detect what other phones were near each other and keep records of that. So that if you later found out that you were positive for COVID, contact tracers, public health authorities could go back and see who you were near and who they need to warn, who they need to issue a quarantine to, what have you. And there was a huge amount of buzz about this for the first 6 months or so of COVID. Apple and Google quickly created and announced the standard and actually put it in their operating systems. Apple and Google, of course, a duopoly that control the operating systems of 99% of American cell phones. And they activated that. Virginia and many other states stood up apps to do that. But the whole thing kind of fizzled, and we predicted it would. We thought that they actually did a very good job on the privacy. It actually, your phones would exchange numbers so that you didn't necessarily know who you were near, and it was hard for the authorities to abuse. And we thought that that was important, not just to preserve privacy, because we care about privacy, but Americans, you know, are hugely suspicious, as we know, about government and so forth. And so if this was to have any chance of success, it needed to be something that people had confidence would not be an invasion of privacy. And I think that that mission was achieved. The problems are that, as one expert put it, actual transmission of COVID is actually very rare compared to the number of interactions that people have with each other. And contact tracing is very hard. It's a difficult thing that epidemiologists do in diseases, and they understand that it's a complex human thing that's hard, because if you're asking somebody who they were in contact with, you're asking them to tell you, the government, their friends that they spend time with, which could result in their friends being quarantined, missing 10 days of work, childcare, parental care, et cetera, et cetera. And so people are often very reluctant to share that information. And so epidemiologists describe that as a very human skill. And contact tracing is a lot harder when, number one, the disease is transmitted through the air. It was a lot easier to do contact tracing with AIDS, where basically you had to have sex with somebody or a blood transfusion or the like in order for it to be transmitted. It's a lot harder when the disease is transmitted through the air, and when asymptomatic transmission is common, and also when the infection rate in a community is just very high. Basically, if it's rampant in a community, there's so many cases that contact tracing becomes, hopeless. And then let me turn to the hot button issue of vaccines. So when it comes to vaccines, I'm going to talk about three different issues: equity, vaccine passports, which have been proposed, and vaccine mandates. Initially, there were a lot of equality issues around vaccines because it was difficult to get them, and you had to sort of figure out how to work the system, work the computers or whatever. And so many of the people who got vaccines early were high socioeconomic status people and well-educated people who could figure all that out. That issue is obviously faded with vaccines today widely available. Although there do remain barriers. A lot of people are unable, and as a practical matter, to get a shot. They have 3 kids, they have 2 jobs, they have bad bus service, they don't really know where to go get one, et cetera, et cetera. And even more often, they don't feel like they could be sick for a couple days with the side effects of the first or second shot, and miss work. They don't have paid sick leave at their jobs, and so forth. And a lot of people have, especially Black people and other people of color, have historically well-founded distrust of the medical establishment, going back to the Tuskegee experiment and just general poor treatment by the medical establishment, and are vaccine hesitant. I think, so there are issues still around vaccine equity, but I think, it's obviously getting easier and easier by the day to get one. And communities are, as they should, are making efforts to reach people who are unable or are unwilling to get vaccinated for those reasons. Another issue is, so you got vaccine mandates, which I'll get to in a second, but if you're going to have a mandate, if somebody is going to require you to get vaccinated, there's a lot of questions around how do you prove that you got vaccinated? And that's what's been called vaccination passports or vaccination, authentication or what have you system. Obviously, this has been an issue for 100 years and so, and you had paper things, you had green cards for traveling internationally, et cetera. Today we have our CDC cards, sort of, again, similar to some of the stuff I talked about, there are a lot of people who are pushing digital vaccination passports. And this raises a number of civil liberties questions. And there's a whole sort of area of big companies and others who are looking to push digital identity systems in the United States. There are people working on digital passports, which I did a recent report about. A lot of companies want to be able to actually have you prove who you are over the internet. So they want a digital system that will allow you to prove who you are online. One of the dangers there is that every website you go to is requiring you to, present basically a online driver's license, and you can't do anything anonymously anymore. That's a separate issue, but that sort of issue of digital identity is looming behind this. And a lot of those people see COVID as an opportunity we've been trying to get this pushed through. We have chicken and egg problems. We need to get adoption. Here's our chance. We're going to use these digital identity systems for vaccination passports. And there are big equity problems here, but because a surprisingly large proportion of the American public does not have a smartphone, including like 40% of people over age 65, and many other of our most vulnerable citizens. And so there are questions about, what do you do if you don't have or want a smartphone? There are also privacy questions. If I have a paper card and I show it to you, you look at it, that's it. If I show you a digital thing, then it could be that the entity that issues it gets automatic notification of everywhere that I'm showing it. It uses it to track me and the like. And that might be one thing with COVID, but if the COVID vaccination passport then, in addition to COVID vaccination, starts having your other vaccinations in it, maybe your other health records, maybe other records, your gym pass, your driver's license, and next thing you know, we have what a lot of people in the industry hope we have, which is a standard for a digital identity system. The vaccination passport becomes that, and if it doesn't have good privacy protections in it, it could have ramifications for decades, including enabling the tracking of things that we do online, even worse than they are now, and so forth. So that's an issue that's been controversial in the technology area. And then, of course, the third of the issues that I want to talk about, sort of vaccine mandates here. Our position is that, as a general rule, people have a right to make their own healthcare decisions, including the right to refuse treatment. And there's a long, dark history of involuntary medical procedures and treatments that intrude on people's bodily integrity and undermine their privacy. And that is a history that needs to be borne in mind. However, in light of the grave risk presented by COVID-19 and the demonstrated safety and effectiveness of the authorized vaccines, we think that vaccination requirements can be consistent with civil liberties principles. The sort of, approaching it from the framework that I outlined that we developed under AIDS. The gravity of the harm, the characteristics of the disease, the degree of intrusion, the effectiveness, the availability of less restrictive alternatives. We think that that vaccine mandates can be justified by employers, et cetera, in some cases by stores. The courts have generally backed up vaccine mandates. Jacobson versus Massachusetts is the case in 1905, holding that a state statute mandating smallpox vaccination was constitutional. A 1922 case upholding a law conditioning school attendance on student vaccination, and a number of other cases over the years. COVID-19 is highly communicable. It can cause death or not any number of serious conditions, has led to 600,000 deaths, has overrun hospitals, and pushed our healthcare system in some cases to its breaking point. It has had a vastly disproportionate effects on some of our most vulnerable communities, and has had a devastating effect on our national economy, education, and community life as we know it. We have had a lot of internal discussions about this, but at the end of the day, vaccine mandates is not something that we think is worth opposing on civil liberties grounds. Let me pause here for questions. Hi, Louise. I don't know if you're, I can't hear you. If you're...
Louise, you're muted.
Now I'm unmuted and now I'm showing, I think, right?
Yep.
What do you know about the strategy developed by Obama administration that Trump people supposedly ignored? Now, maybe that should be postponed a little bit. Yeah? Okay.
I'm not sure exactly what he's referring. I mean, there was maybe the questioner is referring to the White House Office of Pandemic Preparedness, which was stood up by the Obama administration and dismantled by the Trump administration.
I think that's supposedly there was a playbook, wasn't there, that was in place?
Yeah,
a pandemic playbook.
there have been a huge amount of preparation for this, because if you look at, you know, if you read, and I gave you a glimpse of this with the epidemiologist experts, public health experts who wrote that we commissioned to write a report, but in the field as a whole, everybody knew this was coming, and there was extensive discussion, and you know, in retrospect, it all looks very prescient. But it wasn't especially prescient to sort of understand that this was going to happen. And there was an enormous amount of attention to it within the government. You know, we have all these giant security agencies, and a lot of them worked on this issue. And you know, especially after the national trauma of 9/11 and the concern about sort of giant national disasters that pervaded the sort of zeitgeist after 9/11, and with the anthrax thing in particular. I remember seeing a number of presentations by people from DHS in the Bush years about how bioterrorism was inevitable because the scientific knowledge for how to manipulate genetic codes of viruses and so forth was so broadly democratized. It was definitely something that, you know, there was a lot of preparation for, both in the public health profession and in the government. It, you know, all those playbooks really seemed like they were thrown out the window by the Trump administration, because they
were there in these playbooks, were there specific steps, or was it just generally this is going to be important? I mean, were there specifics that somebody could have followed?
My understanding is yes. I haven't looked at them myself, but yeah, I mean, that's a lot of what sort of the security agencies do, is they prepare sort of contingency planning for all kinds of, you know, disasters, and so my understanding is that yes, there was, but I don't know that for sure.
Now, Jay, we have other subjects. We have other questions here. The question to you is, would you like me to continue to questions, or do you want to continue talking, and we'll hold them all till the end?
Why don't we do some questions for a while?
Okay. So one question is, so was I and others just stupid? Starting in 1969 with my first trip to Europe, then in the 1980s to Africa and the Middle East, I was required to produce the yellow book showing timely vaccinations that country required: typhoid, yellow fever, tetanus 9 SP. I'm not sure what that is. Never occurred to me that the countries couldn't do that. I assume the USA has requirements for incoming visitors. Was I just stupid? Also, never occurred to me to falsify through the fraud would have been easy. So that, you know, we've all been to countries and required things before we went there. Is that a fact? And what's the problem then in terms of asking people to show vaccinations now?
Yeah, so the thing that to be clear, what I was being very critical of was digital, specifically digital vaccine passports.
Okay.
I think that if somebody's going to impose a mandate, and as I said, we don't oppose mandates, it can be fact specific, but we don't oppose mandates in general. Then yeah, of course it makes sense. You're going to have, if that's to be administered, you're going to have to prove that you're vaccinated. And there are different ways to do it. One is just to have people show their CDC card, which is, as the gentleman, I think it was, or ladies, you know, said that, like, yeah, we used to have this carte jaune or yellow card that was widely used. It was an international standard that you would use when you were traveling to another country. And yes, the CDC card, like the yellow card, can be forged, and that is a problem. It's not nothing to forge it. You have to, you know, you can go online and you could probably go to some dodgy websites and buy one, or you have to sort of figure out how to do it yourself and get the right card stock and so forth. The FBI has put out a statement saying that forging a CDC card is a federal crime because that is an official federal government document with the CDC's logo on it. So it's not nothing. And you're going to have a sort of baseline of fraud no matter what you do. There are going to be people who claim medical exemptions. They can't get vaccinated for medical reasons falsely. And, the question is whether the advantages of building this digital system outweigh the disadvantages of the potential for fraud with the card. You can also have digital systems that are paper. You can set up, there's a whole thing, public key infrastructure. You can set up encryption so that the party that gives you your vaccine issues a cryptographically signed document that you could either have on your phone or you could have a printed QR code. And that when you present it, the relying party, the verifier, can look at your QR code, read it, check the digital signature against an online directory of digital signers, and then you have cryptographic assurance that that vaccine proof is real. It's a very, very complicated thing to set that up. You have to have apps to generate the QR codes. You have to have apps to read it. The holder has to have an app. Those apps have to be debugged. They have to be widely adopted on some sort of standard. It's not something that's going to, if we are halfway through this pandemic, as someone suggested, then there may be time to develop that, but otherwise it's probably just never going to happen as a practical matter, and we're just going to be using the CDC cards. So yeah.
Gotcha. Another question is, what are the ACLU's primary sources for science information that lead to its position recommendations? Your primary sources of science information.
Yeah, we have a science fellow who's a scientific PhD who helps us interface. We also have relationships with a number of leading public health experts that we talk to directly, who can sort of give us what the general sense of the field is, and as well as following sort of the general sense of the field in the media.
Okay. Relative to your discussion about Bluetooth technology, it suggests that we should go ahead and delete the Virginia tracing application because that was a thing for a while. Is that true? That anybody that has it, that we should delete it and it's not operational and not effective?
That's a judgment call for each individual. I have it on my phone, or I did, and then I got a new phone. I didn't bother to put it back because it just seemed a little silly. I haven't heard of anybody who's gotten an alert. There are real questions about the effectiveness of it, even though it's much more effective than sort of gross location tracking that I was talking about. The thing is that if you are diagnosed with COVID, the contact tracer is going to want to know who you may have spread it to in the preceding days, when you may have been sick enough, or when you may have been contagious, but not sick enough to go and get in your bedroom and sort of isolate yourself. And we have a lot of sort of fleeting encounters with other people, and then we have more sustained encounters with other people. And the sustained encounters we remember. The contact tracer, we can tell them, I had dinner with these two people and lunch with this person and drove in a car with this person. And then the fleeting ones you don't remember because you just passed them on the street, or you sat 4 tables away at a restaurant or what have you. And the question is, how useful is, and there's a ton of sort of fleeting things that are never going to give you COVID. How useful, the space for that app is between the sustained ones that you remember and the fleeting ones you won't remember that may have given you, where you may have spread COVID, and that space may just be too small to be useful. And so old-fashioned contact tracing, may be just better. And seems to be better, and that's the way it's kind of working out. And how many people, if you put this app on your phone, or you have it on your phone, and you get some notice that you have to, you're feeling fine, that you have to isolate yourself for 10 days based on something on your phone, are you going to do it? So there's compliance questions there too. It's different from getting a knock on the door from somebody who's got Public Health Arlington on, a card or what have you. So I think those are some of the reasons why, it hasn't succeeded. But in theory, you could get a useful notification, or if you get identified as COVID positive, the app could identify somebody that you may have given it to that you wouldn't have remembered or known. I just haven't really heard of too many cases of that ever happening.
Sure. Another question is, the EU seems to have figured out a passport for COVID, and they are very privacy conscious. Do you know how they approach this issue of passports for COVID?
That's a really good question. I have not had time to dig into the details of the EU's, and it is true that the EU is better. Well, the EU is better on privacy when it comes to the private sector, like companies. They are often no better and often worse than the US when it comes to privacy vis-a-vis the government. So I don't know the details of how they've architected it, but it is something that you have to really dig into the details, because these things can be done well. They can be done in ways that protect privacy. And then they can also be done in ways that basically become a tracking system that reveals allows all kinds of data to be collected about you in ways that would never have been possible without a digital version. And the more places that you end up having to show your passport, first of all, if a passport is developed and it becomes very, very easy to show your passport, to show that you've been vaccinated, then it becomes easy for people to ask you to be vaccinated. That means that you're going to be asked more and more often. You could be asked, or in Europe, they could, end up in a situation where you are literally asked at every turn for that passport, especially if the pandemic continues on for another, year or plus or what have you. And so now, you're starting to see the privacy issues get a little bigger, because it's really creating tracking of everywhere that you go, potentially who you're with, and so forth. And then when you think about, as I said, that becoming a precedent for all kinds of other, digital identity use cases, it gets even bigger from there, including like online and so forth. So.
Another question is, it's interesting that the ACLU does not view vaccine mandates as a civil rights issue. Why not?
So we do think, well, I don't know if the questioner meant civil rights in particular or civil liberties in general. So we do think that it's certainly a civil liberties issue, as I said. I mean, we think that there is it's a tall order to justify a mandatory vaccine, but that order is met in the case of many diseases, including COVID. So it's not as if we don't think that there are civil liberties issues there. In terms of civil rights in particular, that is an issue, and we discussed it a lot. It is true that a disproportionate number of people who are not vaccinated are African American, Latino. And so if you were to allow mandates, you may be disproportionately harming people from those communities. And on the other hand, there are issues that go the other way. For example, the rights of the disabled. If you are a disabled person who has a disability that precludes you from getting vaccinated, for example, people who are organ donor recipients, who are on a lifetime course of immunosuppressant drugs, can't get vaccinated often, is my understanding. I'm not a doctor, but are those people to be required to be excluded from public life because it's too dangerous for them to go into any public forums? That's another counterbalancing thing. And so we looked at the totality of all the circumstances and landed on thinking that the mandates are acceptable to us. I do think that if mandates became so pervasive that, for example, you living in a vulnerable community can't find a grocery store that will let you in, that becomes kind of a problem. So I think that sort of there are potentially other issues that lie there, but we're nowhere near that kind of a scenario at the current time. So
the issue of mandates, is there a different point of view about mask mandates versus vaccine mandates from your standpoint?
no, not really.
No, it's the same issue, mandates.
Yeah, I mean, it is an incursion in freedom in both cases to mandate it. I'd say more serious in the vaccination case, if anything, because it's you know, it's an injection of a foreign substance into your body. It is an incursion on your freedom, but civil incursions on freedom are justified in the face of a serious communicable disease, and if they are, you know, safe, effective, proportionate, and commensurate with the risk at hand. And I think that masks and vaccines both fit those criteria.
Does full FDA approval of the vaccines, and Pfizer they just approved this morning, make vaccine mandates more acceptable?
I think that they, I think that they do. It was not a crucial point for us, because I think that the evidence was already quite clear that this was beyond an experimental vaccine. It had been given to, I don't know how many tens of millions of people around the world with with very, very few reports of serious side effects. And by the way, serious side effects have always occurred with vaccines. There's actually a federal fund that pays out money to people who suffer severe side effects from, you know, the childhood vaccines that are required in every school in America, practically, you know, MMR and so forth. There's a tiny proportion of people who are harmed by those vaccines. But the judgment of society has been that the benefits of vaccinating everybody far outweigh the tiny number of people who are harmed by these vaccines. And so we pay the people who are harmed by these vaccines through this I can't remember what it's called, federal vaccine fund or what have you. But you know, the side effects of these vaccines are tracked very carefully by the CDC, by private organizations, in some cases, apps, by other governments around the world. And they appear to be very safe. And it was already clear that they were very safe before today's announcement and with regard to the Pfizer vaccine. And so for us, that was not a key issue. I do think as a practical matter, it will probably have large effects in the United States, because a number of organizations were hesitating to impose mandates because of that, and others were using that as a way to argue against vaccines.
Now, you talked about mandates by employers. Now, how about mandates by the government? And I'm not exactly sure what the questioner was asking about. Government relative to their own employees, government employees, or government generally, mandated by the government.
Yeah, no,
it's an
interesting question. I mean, we're not seeing that now, and to be honest, we haven't like sat down and sort of talked about what we would think of that. For example, if the state of Massachusetts mandated that every Massachusetts resident get a vaccine, as happened with the smallpox, apparently, according to that 1905 case, we have seen federal government issue mandates for its own employee, although even the federal employee was not a full mandate, because if you refuse to get a vaccine, you just get tested every week and had to wear a mask, I believe, rather than being fired. And the military, I guess, is reportedly proceeding with a mandate, and I don't know the details of that, but yeah, I mean, if a state were to do that, and most of this is the state level, I don't know whether the federal government has authority to issue a nationwide mandate. I don't think it's really been discussed or contemplated. You know, I don't know whether we would think that's, to be honest, we haven't talked about it, and I don't know whether we think that's proportionate and necessary. I mean, if you live in a, you know, by yourself in a cabin, and your job is a, you know, telephone lineman, and you go around all day by yourself fixing wires on a pole in the outdoors, should you have to get a vaccine if you don't need to? I don't know. I mean, you know, Yeah, it's a good question though.
Somebody was alluding to something you said earlier, and their question was to your last point, that theaters who say require vaccinations to attend is there a possibility they'll be subject to civil liberties challenges, or do civil liberties issues apply only to government entities?
They won't face a challenge from us. They'll probably certainly face, legal challenge from anti-vaccine activists, but we think that a vaccine mandate in that kind of a situation where you are congregating indoors. I mean, I guess they can be outdoor theater too, but let's assume it's indoors, the chance of transmission is high. It's not really an essential facility. You don't have to go to the theater. And so, we wouldn't oppose that.
Somebody asked the question, can you repeat the 5 factors that are considered when evaluating all of this mandates and the severity of treatment versus the issue at hand, the disease?
Yeah.
5.
Yeah. So number 1, the gravity of the harm. Number 2, the contagiousness and other specific characteristics of the disease at hand. Number 3, the degree of intrusion and the duration of the proposed health measure. Number 4, the effectiveness of the proposed health measure. And number 5, the availability of less restrictive alternatives. When this pandemic first arrived, we couldn't help but see it through the lens of 9/11, where the national emergency, national crisis was used and exploited by various institutions to increase their own power, to get things that they'd always wanted, such as the Patriot Act, which had been specifically rejected by Congress in the 90s under Bill Clinton, but they took it off the shelf, blew the dust off it, and rammed it through in a matter of weeks after 9/11 without any sort of finding that the actual problems that led to 9/11 would be solved by that piece of legislation. And so, we have always been and continue to be concerned that COVID would be used to institute measures that would outlast COVID. They would be used as a rationale, that the crisis would be used as a rationale, as an excuse by various institutions to do things they've always wanted to do, whether it's tracking people in different ways or what have you. And you see that in some particularly limited ways. For example, a lot of stores are going cashless. And we have some civil liberties problems with cashless stores because it's bad for privacy, it's bad for poor people, it's bad for the undocumented to not, it requires getting ensconced in a bureaucratic systems in order to get the kind of electronic payment system set up that a lot of people, homeless people, don't have access to, et cetera, et cetera. And we think that we should keep cash. But a lot of stores are using COVID as an excuse to refuse to accept cash, as if you're going to get COVID, as if, we're living in March of 2020 when people thought maybe everything was about surfaces. And the experts say that while theoretically possible, like nobody's going to get COVID from touching cash, but we still see stores using COVID as an excuse. And that's just one tiny example, but we are continue to sort of be vigilant in asking that COVID measures be time limited.
Somebody made a comment, I've been astounded by the number of people discounting the science. Could you speak some more about the prediction you made in 2020 about people not listening to science? What have I been missing?
Yeah, that sort of came out of our experience with Ebola, where all the scientists were like, you don't need to quarantine people before they have symptoms because they're not contagious until after, in many cases, well after they have symptoms. And these people you're quarantining, you've got some public health official in New Jersey who's quarantining a doctor who just came back from working on Ebola and knows way more about Ebola than you do. And yet, inflammatory figures like Donald Trump and the tabloids and a number of governors were all up in arms about the dangers of Ebola, and it's going to come to our shores, and you know, and a lot of these governors didn't listen to the scientists. And even the Obama administration, which was pretty good on it all, was, you know, faced a lot of pressure to do things that were not only unjustified but also counterproductive. And so, you know, that's where that prediction came from by me. And you know, we sort of, not to mention, you know, epidemiologists talk about, you know, hundreds of years of panic and you know, stigmatization and worse attacks on vulnerable communities. So you have to have a healthy respect for the darker side of human nature when these diseases come around.
What are the ethical considerations when there isn't enough capacity for treating patients about prioritizing treatment for patients who responsibly were vaccinated? I guess it's the issue of vaccinated versus unvaccinated people, and treating them equally when some people were more responsible in getting a vaccine and some weren't, and they both end up in the hospital. I think that's what they mean.
Yeah, I mean, I'm not an expert on medical ethics. You know, what we just generally call for is that, you know, no sort of panic or what have you around the pandemic be used to force deviations from what the medical profession and it's, you know, many decades of hard thinking about the ethical issues involved in triage, for example, and so forth, that they be respected. I mean, doctors, my understanding, again, I'm not a medical ethicist, but my understanding is that doctors understand their oath to be that they treat people regardless of innocence or guilt, personal life decisions that they may have made. Their role is not to make judgments about people's lives and the decisions that they made that led them to the hospital, but to treat the people as they are, as best they can once they arrive.
Somebody posted a site here of how people can get their Virginia COVID vaccination record, which is vda.virginia.gov//coronavirus. I'm just passing that along. You have a cheerleader here. Hooray for the ACLU on masks and vaccines. Next question is, what are the chances that the ACLU will charge politicians with depraved indifference or neglect homicide for their partisan responses to COVID? Wow, we'll be here the rest of the night.
Yeah, well, many may deserve it, but there's no such action to be taken in our system of government. There's a long history of stupid and tragic policy decisions that have led to many deaths, unfortunately.
So there's no mechanism to hold anybody accountable.
I mean, the mechanism
by politicizing it.
The mechanism, not through the courts. The mechanism is to, I mean, unless there's specific violations of the law as passed by Congress or by state legislatures or what have you, or the Constitution, obviously. But otherwise, it's up to the voters.
Gotcha. As somebody clarified, Steve Burdell clarified the website that I referred to. It's VDA, meaning Virginia Department of Health, not VDH, not VDA, in that website that I just gave. Somebody also commented, Jay, earlier in your presentation, you talked about the H1n1 flu or virus, I don't know how you call it. And you mentioned that President Bush overreacted to this outbreak, but he wasn't president at the time. The person's commenting when H1n1 was discovered, and President Obama used the Bush administration playbook to handle this. And then they sent a link on. So I'm just passing that information along.
Okay. I wasn't aware that I had said that. I may have misspoke if I did. But yes, I think I said that Obama responded relatively calmly and rationally to the H1n1 outbreak. But yeah.
But he was president when it happened. Obama. Yes.
Yeah, it was 2009, April 2009.
Another question is, I never heard of chickenpox parties. Can you say a word about that? Do you think there is an element of that in deliberately attending so-called COVID super spreader events?
Yeah, I mean, apparently, and I don't really remember this myself, but it was common for parents to intentionally expose their children to chickenpox. For example, if a child in the neighborhood had chickenpox, the other parents would bring their children over to get chickenpox because it was relatively mild when you got it very young. But obviously, if you get chickenpox when you're older, it can be much more serious. And also sort of to get it out of the way and so forth, because for most people ended up getting chickenpox. And now, of course, there's a chickenpox vaccine, but and so, you know, the concept is the same, which is that you know, if we were to have had that that immunity passport, that it would have incentivized that same behavior, and that would have not only been unfair that some people would have been in a position to have to take the risk of exposing themselves to COVID, but also it would have been enormously counterproductive in trying to stop the spread of COVID if you have people out there intentionally exposing themselves. So again, it's a situation where civil liberties of the individual and the collective interests of the biomass align pretty well in that case.
I haven't heard about them lately. There was kind of a moment where you heard about them, and now I haven't heard about them lately. I don't know if you have. So these parties.
There was talk of sort of COVID equivalent chickenpox parties, like in the early months of the pandemic. Right. But yeah, I haven't heard about. I think there's a lot of people who don't, you know, who are cavalier about it, but I don't know about intentionally exposing themselves. I think a lot of the news about long COVID may have dissuaded people from rolling the dice on that, because even if it doesn't kill you, it can really, you know, harm you.
Yeah, yeah. Can you discuss the religious exemptions to vaccine mandates in detail with regard to civil liberties, religious exemptions?
Yeah, so in our view, whether a religious exemption is required kind of depends on the circumstances. If basically if an employee has a sincere religious objection to taking a vaccine, the employer has to provide a religious accommodation unless doing so would create an undue hardship for the employer. The thing is, of course, that under that standard, any kind of proposed accommodation that threatens the health and safety of other employees would constitute such a undue hardship, and so probably religious exemptions would probably not be necessary in those kind of situations. And you know, outside of the employment context, you know, if there's a strong interest in requiring people to get a vaccine, that same strong public interest that outweighs the, you know, so there's a presumption that you don't force people to get medical treatments, but the situation is so big that it outweighs that presumption. It probably also outweighs individual non-medical exemptions. So if the need for a mandate is big enough to justify a mandate, it in many situations is going to be strong enough to justify the lack of a religious exemption. That said, the Supreme Court has been very, very protective of religious exemptions. The New York governor issued an executive order that capped religious services at 10 or 25 people, and other gatherings as well. It wasn't specifically about religion. And the Supreme Court, in a case called Roman Catholic Diocese of Brooklyn versus Cuomo, voted 5-4 to block enforcement of that rule, and stepped in with other unsigned orders, struck down a Colorado and New Jersey restrictions. I mean, our view is basically like, and we have a, you know, we have a religious freedom project, and we fight for religious rights in many contexts, but we also say, as my colleague said, the freedom to worship is one of our most cherished fundamental rights, but it doesn't include a license to harm others or endanger public health. And there was a Supreme Court case in 1944 that found that, quote, the right to practice religion freely does not include liberty to expose the community or the child to communicable disease or the latter to ill health or death. So the Supreme Court has been very protective of that. They have been much less protective of other constitutional rights. For example, the treatment of prisoners and detainees has been horrible during COVID. People in prison, jails, and detention centers frequently, are in poor health to begin with, and they're often denied adequate nutrition, healthcare, fresh air, access to fresh masks, often just even to soap. And unsurprisingly, the rate of COVID in prisons and jails is 4 times the national average. The mortality rate is twice that of the general population. Jails and prisons haven't put in place even minimal precautions, and people in those situations have no independent power to protect themselves. There was a 1976 Supreme Court case found that prisoners have a right to reasonably adequate health care. And yet the Supreme Court has blocked several lower court orders that prisons and jails that weren't doing anything to protect their inmates, protect the prisoners, and the Supreme Court has blocked those. So the Supreme Court seems to have a very selective view of where constitutional rights come into play and where they don't. There was a situation in Orange County where cases were multiplying, and the district judge found that the jail response was piecemeal and inadequate, failed to safeguard the health of the inmates in its care, and the Supreme Court blocked his injunction. That's been a major priority for us at the ACLU. We've secured release of over 10,000 people from prison, jails, and detention centers, people who are in those situations but are not a threat to the community. And so, as some critics have pointed out, like Brandon Garrett and Slate, the Supreme Court is activist when it comes to religious restrictions, but refuses to act to defend other constitutional interests. So it's a terrible situation.
Would the ACLU modify its 5 factors based on the national COVID experience?
I'd be interested if you have suggestions for ways in which they should be modified, but I think they hold up pretty well. The gravity of the harm is high, the specific characteristics, it's contagious. It's contagious by asymptomatic transmitters who don't know they're sick. The degree of intrusion of the proposed public health measures is not extreme. It's vaccines, which have long been given and mandated. It's masks, which are not, such an imposition. The effectiveness of masks and vaccines is not seriously debated by the medical community, and there's not really any less restrictive alternatives in general, although there can be specific situations.
Well, we're getting to the end of our time. Clearly, there's a lot of interest in what you have to talk about, Jay, and your expertise is greatly appreciated. So I would like to thank you for being with us today. I represent everybody here. There were over 100 people on this call. So thank you very much for that.